Thanks everybody for joining us. This is the Joey open mic session. We're going to be talking about cryoanalgesia, and the product that most of us have been using is something called iovera. If you have any questions, just housekeeping, please type them into the chat, and then we'll try to answer them as they come through. And then we can also open it up a little later for questions from the audience on your camera and on your mic. So first, we'll go through the panelists. We'll introduce ourselves. I'll go over the technology, and then we'll kind of work through the group to figure out how they got introduced to iovera, kind of where it's landed in their practice and what they've seen. And then we'll talk about different ways of using it and kind of where we think the future is going to be. So my name's Dr. Dasa. I'm an orthopedic surgeon. I'm in sunny, balmy New Orleans right now. Been practicing at LSU for the better part of 17 years, and I started using iovera back in 2013, so a little over a decade now. And we'll talk a little bit about the science in a little bit. So I'll hand it down. Who wants to go?
I can go next.
Sure.
I'm Clay Guynn, physical medicine rehab sports medicine provider in Atlanta, Georgia with Northside Hospital. My partner's on the panel too, Dr. Levengood. He was also my first patient that I treated with iovera. And started out with that. We use it a lot in our practice for pre-total knee, but since then it's kind of, I do it for a lot of things now, for hip, for ankle, shoulder, ribs, pain of spasticity, occipital nerves. I've kind of been finding nerves all over the place and been freezing them for the last couple of years now. So,
Great. Next.
I'm Gary Levengood. Clay is my partner. We started this about 2.5 years ago when I had my total knees done. I'm an orthopedic surgeon in Atlanta. Read Dr. Dasa's tome about iovera and how successful it was, and I was going to have my own knees done, so I sent Clay down to get trained on it so that I could have a non-opioid experience.
Great. Bill?
Hello, everybody. I'm Bill Uhlrich. I'm an orthopedic physician assistant with Dr. Greg Martin, who's on our panel as well. We implemented iovera almost 4 years now to our pre-total knees. We use it in our painful total knees and osteoarthritis patients that are not surgical candidates. Been having great success with it. It's an integral part of our pre-op package now, and pretty much all of our patients do take it and doing some great work, and it seems to be changing post-operative pain for the better on most of our post-operative patients.
Greg?
Yeah, Greg Martin. I'm an orthopedic surgeon, personalized orthopedics of the Palm Beaches in Palm Beach County, Florida. Over the 20 years of my career, I've kind of made it it's a passion of mine to how do you make the surgery easier to go through. So I've always kind of always looking for the cutting edge on whether it's pain management or surgical techniques or implant technology, anything that can make knees easier to go through. So I followed the trajectory of this technology prior to the Pacira acquisition when they were smaller, and I was always interested. I actually saw some of Vinod's early papers, very interesting. But the company didn't really have the bandwidth. But then when they got acquired by Pacira, we reached out to them, and we were users of the other Pacira products. So I was enthusiastic. We had the connections, and we started using it, and pretty much instantly started to see a big improvement in the patient outcomes, reduction in narcotics. So we pretty much offer it to all new patients undergoing total knee arthroplasty, and we do use it in patients that are not great candidates for surgery or don't want it, and like Bill said, and sometimes in these painful total knees that have ongoing issues. So
Great. So just to kind of get level set for our audience, what we're talking about is a technology called cryoanalgesia. The brand name is a product called iovera. And basically what we're talking about is a technology where we create essentially a tic-tac size ice cube under the skin. And when that cold hits any of the sensory nerves, it shuts the nerve down. And then theoretically, whatever that nerve was innervating, that pain is stopped until that nerve regrows. And we know nerves generally regrow about 1 millimeter per day. So depending on how far up you get that nerve from its innervation, you can anticipate what the length of time is for that pain relief. And so you've heard here clinically some kind of initial experiences of some of the folks that have been using it. Gary, what have now you're the ultimate, obviously, person that can really speak to this, both on the provider side and on the patient side. Tell us your experience and kind of how it all played out.
Well, I wanted to find out how to do non-opioid medicine in my total joint patients. And I've been doing outpatient total knees since probably 2007, 2008. And the biggest barrier has always been pain control. And what I wanted to do is figure out how we could do something that would allow patients to have a somewhat painless surgery and be able to get back out and do what they need to do. I was interested in it because selfishly, I knew I was going to have total knees, and I didn't really want to have to take any opioids as well. So I went through the experience of having the ice balls put on my nerves, and it really wasn't that bad, and had a good result with it. It was the sensory nerves, really felt pretty good. It didn't really get rid of the bone pain that I had from my arthritis, but it got rid of the other. I started using it in my patients right after I used it, and been looking at my patients and how they're doing with it. We did a comparison of 50 patients with and 50 patients without. I offer it to all my patients. Those that have, want to pay for it or have an insurance company that will pay for it, will go for it. Usually the people that don't, So I looked at those two groups, and I really found there was a significant reduction in the amount of narcotics. My non iovera patients took about 35 tabs. In my iovera patients, it was down around 20. So I really had a pretty significant reduction. And even with that, a lot of patients will take pain medicine because their relatives and their spouses will tell them they need to take it. They don't want them to be in pain. And a lot of times they'll end up taking it. They don't really need it. But I found that, patients do better. They don't have that initial amount of pain that a lot of patients have without it. And so it's been an extra little arrow in the armamentarium that we can kind of go toward non-narcotic surgery.
Greg, you're in a fairly competitive market down there, right? And you've got to kind of keep up with the Joneses. So what's your multimodal strategy? How has this kind of differentiated your practice? Why was this something you had to do? Why not just do what everybody else is doing and follow the herd, at least in the beginning?
Yeah, I mean, look, I think, pain management and total knee arthroplasty has been, it's been a journey, right? Like when I first started to do this, patients were in the hospital for several nights on PCA pumps, filling their veins with IV narcotics and barely moving. And then they would go to rehab for, a lot of times for a week or two and stay at a place. So it's amazing to think now that, for me, I'm at least 90% of my patients are done outpatient. So, it's been always trying to make it a better and easier to go through. And it's been an evolution, right? So we went from these days where we filled people with IV narcotics to, multimodal pain management with Tylenol and an NSAID and a little bit of oral narcotic and gabapentin and all these things that we use. And we went through, in the early days, we started to do femoral nerve blocks, and they had the weakness issues, and then we moved to adductor canal blocks. But what happens with the adductor canal blocks was you'd call the patients, and I had a window to call them, for about a day. And if I called them beyond that day, they were miserable. And then we started to use Exparel in our blocks. And then that extended the window of time I could call them for 2 or 3 days. But then after that 3 days, that pain was kicking in. So what intrigued me about the iovera was the potential for really long-lasting pain relief. And that's what's been so striking, is that we have these products that can manage the real acute pain, but then they never really get that rebound pain that I was used to seeing with all. So it's always a progression of trying to make it better, better, better. And this is the first time I'm seeing in my career where I'm really satisfied with our pain control throughout the whole journey. It's pretty cool to see.
Yeah, I agree with you. I think one of the important things I realized was kind of that soft landing, when you're coming out of surgery, where you really don't have that cliff that they fell off, like you said, day three,
Mm.
day four, and they can kind of come down easily and transition. Clay, walk us through kind of, what the process is when you're doing these procedures.
Like what the patient experiences and
Yeah.
like.
And kind of, are you using ultrasound? Are you landmark using that big long needle or the three tip needle?
Yeah, so I pretty much always use the 2190, the long needle under ultrasound guidance. So basically, the patient will see Dr. Levengood, or I have a couple other people that refer to, but Dr. Levengood is certainly my biggest referral for cryoneurolysis of the knee. We set them up. They come in, obviously sign a consent form, and then I kind of tell them that's kind of a repetitive process that we'll be doing. We put the ultrasound on there. We find the nerve, clean off the area. We put lidocaine around the nerve so they don't hurt as much during the procedure. Numb each of typically I do 5 nerves, which are branches of the anterior femoral cutaneous, lateral femoral cutaneous, and saphenous nerve. So I usually do 2 branches of the anterior femoral, 1 of the lateral femoral, and then I started out doing actually the 2 like lower infrapatellar saphenous branches, but now almost exclusively I do the saphenous nerve itself, kind of
Up
above,
at the adductor?
before it branches off, and kind of hit the suprapatellar branch and then the saphenous nerve proper as it's going down more towards infrapatellar. And that seems to over time has worked better for me. So as
Clay, do patients complain of numbness going down their leg at all?
So I've never really had many people complaining of it, like going down their, like into their tibia area or anything like that. The patients will say, my staff that helps me laugh about it all the time, but we hear different things. I'd say pressure is, while you actually have the ice ball on the nerve, is one of the most common things that people will say to me. They feel a pressure. But I've heard anything from, I feel pressure, I feel burning, I feel tingling, I feel numbing, my favorite is a patient said it felt like the wiggles. Not sure what that means, but literally I've heard probably 10 to 15 renditions of what they experienced. But when you put the lidocaine in, and the other big tool we use is distraction, just talking about their kids or the vacation they're going on or whatever it is, they seem to do pretty well. I think the handful of few people that haven't tolerated it well, from what we've experienced, are people who don't tolerate most things well. So that would be like your fibromyalgia population, people sometimes with chronic pain, but even them, they tend to do pretty well with it. So it's essentially put the ultrasound, clean it off, numb the nerve, and then switch out for the iVer device. And it takes about 100, so it takes a little longer as far as with being on the nerve. It's 106 seconds that you're on each individual nerve when you use the long needle, whereas it's only 65 if you're doing the trident needle, the shorter needle. But after doing it for a bunch of different patients, I mean, I can do the 5 nerves in about 15, 16 minutes. So, but I have staff that's trained, and they know what I want, and they know when I come in, I want to get ready and start, putting the ice balls down and move on to the next patient. We also, I'm not sure about Bill, I'm sure he can tell you his experience too. We also do offer the deep geniculars as well. We seem to find, I mean, I think it adds a little more of that deeper pain component to it as well. Dr. Levengood could obviously explain what he experienced.
So we actually have a question in the chat specifically about that, going after deep geniculates with the ultrasound. Any tricks that you've got for doing that?
Yeah, so you can find the vessels. There's usually little bumping arteries right by the bone there on the femoral condyle or the tibial condyle, depending on if you're on the inframedial or superior or inframedial on the tibia or superior medial superior lateral on the femur. So you can see that. And the other big one that I found is actually putting the lidocaine down around the femoral condyle. You can often see the nerve a little better too. The lidocaine brightens up the nerve. So you kind of get like a brightening effect that kind of illuminates the nerve. That I found those two being the big help to make sure you're hitting the nerve.
Right.
Yeah, I would agree with Clay. We do the deep genicular at the same setting as the superficial. We're pre-oping them, so it's hard to do the superficial. And then some guys will bring the patient back if it's for OA and see what their response is. If they're getting some posterior pain, they'll go back and do the deep genicular. But we're basically using this for preoperative management. We're going ahead and we're going to take care of all those nerves all at one time. And honestly, we've never had any pushback postoperatively. The patients do well through the recovery. And as far as 3 months, they're doing quite well. So we've never had to revisit that. We just take care of that up front.
Bill, what are some lessons learned? Obviously, nothing is as rosy as we hope it is.
Yeah, I mean, the hardest curve for me was, and I have a radiology background for PA school, so I had a little bit of experience with ultrasound. That was probably my biggest curve, is just doing this, and the more you do, the easier it is to see. I find actually in this case, the heavier the patient, actually the easier it is to find the nerves. Your more athletic or low body fat patients, it's a little bit hard because there's not much space in that adipose tissue to see the nerve, so that becomes a little bit challenging. But I when we teach this, basically it's the more you do, you start to see this. And I always tell people, once you see the nerve, you almost always see the nerve. It becomes very, very easy. So just repetitive. I start out scanning some of the girls in the office in my free time, and just my own knee, just to get better at. And just the more you do, the more confident you become, and more consistent you'll get in your responses.
For people that aren't necessarily ultrasound savvy or comfortable with ultrasound, there's a landmark technique as well, where we can teach you to draw some specific lines and you treat across that line. That's actually how we do most of our treatments in our office, specifically for the knees. It's fairly reproducible, and my PA does it for the most part. So, Bill, what have you noticed? Like, what was kind of the aha moment when you started doing this? Did someone tap you on the shoulder and say, "What is this?" Or is it something that you saw clinically? What kind of sold it?
Well, it's actually Dr. Martin that, back with Myoscience, we originally looked into Cool and tried to get Cool to come and give us a demo, and we never got a return back from the reps. And then we moved over to the Iovera when Myoscience had it, and then once it moved over to Pacira through one of our other reps, we did get our local rep to come in and do a demo. And we basically we picked a handful, about 10 patients, and Dr. Martin chose those. And we started with the triad needle. So I started with the landmark technique, and we had great success out of those patients. And then as we continued to do this, and our body habitus changes, and our heavier patients, I started to see somewhat of the limitations of the trident needle in bigger patients. And so having the ultrasound machine in the office, and as I inquired as far as moving towards a more specific approach with the 190 needle and the ultrasound guidance, it was kind of a natural progression to move to that, one, to speed things up and minimize the amount of injections and the procedure time. And it was just, we never really looked back. I haven't been back to the trident needle since then. And that's coming up on 4 years now. A little over, probably close to 1,000 patients, I believe.
So, Gary, why do this? Let's just keep prescribing 20, 30 Percocets. What's the big deal?
Well, my thing is, I don't like to round on patients in the hospital. So everybody is going home. And I have 99.9% of my patients go home. So anything that I can do to prevent them from having problems with pain, I'm going to do. And, when I start giving them narcotics, then they start falling and they start doing crazy things. And so if I can stay away from that as much as possible, I want to. And I think, it's really pointed out, it's that initial pain that patients feel after surgery. If you can blunt that or get rid of it, then you can get them up and you can get them walking. You can have them do stairs. You can do all the things they need to do. And then they're confident that they can go home and do well. And so that's the reason I use it, because I really want these patients to not have any pain post-operatively, to get a bigger window than, a day or two from a ductal canal block, and really get out there and be able to participate in physical therapy, walk, do stairs, and do all those things and do it safely.
Greg, how has this differentiated your practice in your market?
I mean, I think it's all about the patients, right? I mean, at the end of the day, that's what this is about. I think what I like to say is prior to us utilizing this, I always say there's 20% of people that are superstars with knees, right? Like no matter what you do to them, they have no pain. They're happy. They come in tap dancing, and we love these patients. We videotape them walking up and down the hall a week post-op like nothing happened, right? But those are outliers. And then we have outliers on the other side, right? That 20% where it was so terrible and so painful that like it's like worse than childbirth and it's the worst thing they ever did. But for the average people in that middle, that 60%, it was traditionally a very tough surgery. So what I like to say now is it's taken that 60% and it's made them superstars. So now what I see is about 80% of my patients are those superstars, and I still have that 20% that, find the surgery hard to go through. But even purely objectively, when we look at that 20%, they're getting it through it easier than they used to. I mean, they're using less narcotic, they're going home on the day of surgery. So if you look at it from a purely objective standpoint, really almost everyone is doing better with this technology. So
Clay, I mean, this seems like a no-brainer. I mean, we should be handing this out like candy. Why is this not everywhere all the time at this point?
So, I mean, the specific challenge, I mean, we see all the time in Georgia, at least I can speak for Georgia, of course, but is the insurance, right? Like I have a buddy up in Pennsylvania. It's covered better in Pennsylvania than it is in Georgia, and it's variable per state. So, and I think Dr. Levengood would also echo this. I mean, most of the patients they're pretty down for it, except the financial side of it. So, the experience they have is pretty good. I mean, it also helps when your surgeon has experienced it as well, and they can kind of speak to that. So that's kind of a unique thing we have.
That's cheating
in our practice right now. But honestly, for us too, like people come knocking at our door after we did this for a little bit. They friends talk to friends, and people talk at church and things like that. And there's actually been some people that have gone to talking about like the practice itself, just like have gone to Dr. Levengood to get their knees because they say, well, I want to go to a practice that's doing this because you guys are forward thinking. You guys are trying to, decrease opioids. Patients know opioids are dangerous. They, I think, like you said a minute ago, the average patient knows opioids are not great. And if you can take none of them or minimize that, that's really a good thing. Because as being a physiatrist and through my training, I mean, I've seen a lot of people on a lot of meds, and I hate it. And that's really what, along with Dr. Levengood, brought me into wanting to do this. I mean, it's opioid free. Just the results you see with this, it's changed my practice tremendously. Like that, just obviously we're talking about the knee right now, but it's changed the way I treat a lot of other things too. Like I said, I kind of do it head to toe at this point. But for the knee specifically, I think, we've had quite a few patients that have done, one knee with Ivera, one knee without. They'll tell you like they really wish they could have had their other total knee with Ivera because, they didn't have to get a manipulation, or they didn't have to take that many opioids and their valves get clogged up and all those things that we know happen with these opioids because they're dangerous. So I think if we can. I think this is definitely one step closer to decreasing the opioid burden and saving lives, really.
So that's a good segue. Bill, I mean, it's working well in the knee. Where do we go from here?
Well, I mean, Pacira is kind of moving forward with a lot of different aspects to this. In our teaching, we've moved from just the knee and the training seminars to a head to toe approach. And I mean, these guys are using it. I basically use it in knees, and we can do shoulders. We have a shoulder surgeon. We're going to start looking into doing his pre-op patients as well. So in our practice, it's basically utilized mainly in the knee, but we can do some shoulders. But there's different movements in for spinal applications, and foot and ankle and hip, and intercostals for rib pain and rib fractures. So it continues to, every time I do a teaching seminar, the guys I teach with, I'm learning new areas that they're utilizing this. So it's promising to across the board, head to toe, to try and decrease the, like Clay was saying, narcotics. Patients just don't want to take narcotics anymore. And with down in South Florida here, with pretty tight restrictions with the opioid crisis that we had, they've cracked down really hard on us. So we're limited on what we can give anyway. And I don't have pushback with patients anymore. It really, that discussion, it doesn't happen anymore. They get a small prescription, preoperatively, and probably 90% of the patients either barely touch it or don't touch it at all.
Gary, are we at a point where this is a household name, or we still have some work to do with this?
I don't think it's a household name yet, but we've been pushing it pretty hard out in the community. If you want an opioid-free experience, this is your best bet. I think that, word of mouth, like they were saying, is probably the most powerful thing. When people go to church and they come walking in, they had their knee 2 weeks ago, and they're not having any pain, and they're able to sit down and do all these other things. And they ask, how'd that happen? And they talk about it, and then patients come in and they ask for it. So that's how we've put some stuff. Clay's done a good job of writing stuff up for newspapers and the hospital. And so I think there's more awareness of it now. And I think that, and patients too, they ask for it. They ask for that, and they ask for, the outpatient part of it, because they don't want to be in the hospital.
I'll tell you, I've noticed where the biggest impact has been is when the patients are in physical therapy and they're with another patient next to them who didn't get it from some other surgeon, and that other patient staring at them saying, what is going, like, why are you doing that and I can't do that? And kind of one of our biggest cheerleaders are actually the physical therapists, because they see such a stark contrast between these patients compared to kind of traditional, if you will. And they are almost apostolizing this without any kind of push, without any interest on my side. And so it's really been impressive to see the stakeholders around me actually latch onto this and grab onto this more than me. And they actually put all the wind in my sails more than anyone that I've seen.
That's interesting thing. It's like, we're probably the biggest user over in West Palm down in Florida here, and there are a couple other guys locally using it. But we've had some referrals from outside surgeons, some patients that have talked to Dr. Martin's patients and asked why and how they're doing so well postoperatively. And actually, those patients have found their way to us for us to do their preoperative treatment as well for other surgeons locally. So the patients talk. They look. They see each other and like, well, who do your surgery, and why are you doing so well and I'm not? And 9 times out of 10, it's, I had Iovera. So it definitely works, and it's making a difference in the recovery of total knees, which traditionally is a very difficult recovery.
So Clay, when we talk about, like we said, knees are doing well. What about post-total knees? Have you done a painful total knee, let's say 6 months or a year later, and see if this works?
Yes. So kind of multiple different areas there. So, I think it comes into a couple different categories. So one is that comes in is, there's a portion, I don't know exactly, you guys, the surgeons would probably know better than me, but there's a portion of people after total knee that you get this kind of like CRPS situation. It's not a true meets the full criteria CRPS, but I call it CRPS like. So they get kind of like a neuropathic pain for whatever reason that may be. Treated some patients with that. They've done well. So they kind of calm those nerves down and block those sensory impulses, and they're able to get back into therapy. That's usually done a little closer post-op. So I've usually done those within probably 2 months or less from the surgery. There's also, I've had some other outside referrals too of people that they're just not progressing. They really don't want to get a total knee, and the patient's been researching, or the surgeon sent them to me to just get the Ivera, and they were able to prevent needing a manipulation because they weren't getting that range of motion, and it was more of a painful block, not like a true. They had a scar build up that had to be broken. It was just more like a painful.
The pain was holding back.
Yeah, so that's been one. Again, usually a little closer, within a month to 4 to 6 weeks post-op, kind of earlier. But yes, have also treated definitely plenty of people, 6 months, 12 months, more than that even, out of total knee, and they just have that kind of chronic pain. And this is definitely something that you can throw into the mix regularly now in those patients that they've seen, multiple surgeons, or at least their surgeon multiple times. They don't need to revise. They've ruled out infection. They've ruled out back. They've ruled out hip. So I mean, it's the knee that's causing the pain. So in those typical patients, what I'm not sure Bill could explain what they do, but I personally recommend what I do for the chronic pain patient is I do a nerve block before I treat them with like Ivera, or even I do cool leaf RFA as well. But I usually tell them that we should do Ivera. It's a one treatment we can do to try to get the pain calmed down, get them into therapy. But I want to do the nerve block first to make sure they do have a response, because that's something when you treat chronic pain patients, you don't want to just willy-nilly do a treatment on them if for some reason you're missing an L4 radic or a hip arthropathy or something like that. So if they respond to the block, I'll usually end up doing the cryo on them, and then it does help them. And as you alluded to in the beginning, in the chronic pain patient, we tend to go up more proximal. So in a total knee patient, if we're doing it pre-op, you can do kind of mid to distal third of the thigh, and you're going to get plenty of relief. You're going to get 2-3 months at least, usually, of the relief from it, and that's plenty when you have a total knee to have that relief for a couple months or 3 months after the total. But with the chronic pain, I'm treating it up way high, like closer to the inguinal crease and that area. Still branches of the AFC and LCN and saphenous, but just hitting it up higher using that Wallerian degeneration properties of it's a millimeter a day to get more longevity with it. So the book answer is still 3 months, but nerve properties of regeneration are nerve properties of regeneration, a millimeter a day each month. So
what's kind of the anatomic area number 2 and number 3 on your list now after knee?
I would say, let's see, what do I do with myself? So probably number 2 is actually pain associated with spasticity.
Okay.
For me. And then the other one is just kind of smorgasbord. I've done anything from, I've treated neuralgia paresthetica with it, rib fracture, post-herpetic neuralgia, occipital neuralgia, rib fracture, low back pain, SI joint pain, ankle fracture, ankle OA, pretty much kind of like I said in the beginning, anywhere there's a nerve that we can block, if we don't get enough relief with the steroid, we can freeze it.
Bill,
I did want to point out these were referred in to him, not my patients.
Of course not. Thanks for the clarification. Bill, what about reimbursement? What are the headaches around that?
Well, like Clay was saying, it varies from state to state. Medicare in South Florida here covers it. We don't have an issue with that. A lot of the commercial payers, they're still considering it experimental. So we've gone to a cash pay system as far as the commercial payers, and it's offered. We do submit if we get reimbursed, and we reimburse the patient. Medicare down here is covering it 100%. Most of our patients are, whether commercial or Medicare, are accepting it. Every once in a while, I'll get somebody that opts out of it, and again, most of the time it's a financial reason. Obviously, the product works, and we discuss, and it'll make a difference, but it's just a financial issue for them, and they'll opt out of it in a lot of cases.
We've seen so Medicare straight Medicare, we haven't had any issues, but Medicare Advantage, we're now seeing some of the payers, especially Humana, out of the blue, not out of the blue, I'm sure they were thinking about it, but last probably 3 months, all of a sudden went from like 80-90% approval to like 80-90% denials for Humana managed Medicare. And it's really been a big headache for us here. What, as far as cash pay, what are you guys charging?
We are right. I believe we charge 900. Medicare allowable in that regards. But we're doing again. I do the deep genicular and the superficial at the same time. There are some guys that'll break it up. I know Josh Urban has a 2-tiered system. He'll do superficial and then he'll bring you back and do deeper. So a lot of the guys are doing different. I've heard anywhere from 500 all the way up to $2,000. So.
Got it. Ira, you're on. Did you?
Yeah.
You're here? Okay.
Yeah, sure. I want to make a couple of comments if that's okay. First of all, Gary, you are winning the award for the best virtual background, which is not virtual actually. We don't usually. I want to take a picture. If you step away, I just want to take a screenshot of your picture. I could use that as my virtual background.
There you
So
go.
I too could be the world's greatest dad and have beautiful artwork. I think it's a great thing. One of the things about the way we evaluate a new pain technology, a lot of people make, I think, a little bit of an error of how many opioid pills are they prescribing per patient, or they'll do 200 patients with it, 200 without, and then they'll say they use the same amount of opioids. And from what I'm hearing, that's not really a good outcome measure for this. What I hear from Bill and Greg's practice and from you, Gary, and from Clay is that people are talking about it. I call them the church ladies where I am. They say, I'm not going to have a joint replacement because 2 people at my church didn't have it. And I tell them that, I know Pastor Parsons, and he told me that Jesus wants you to have a knee replacement. So I have my own lines I use in the Bronx, but the reality is that this infatuation with trying because there's so many confounding variables when dealing with opioids in a cohort of 200 versus other 200. What I'm hearing is other outcome measures here, like the physical therapists are talking like the people are being referred into Greg and Bill's practice. People are referred over. Just some comments about that, about how we could possibly look at sort of objectify some of those other measures instead of just always looking about, I can do this operation in 5 opioid pills. It always feels like name that tune. I could do this operation in 4 opioid pills. I cannot do the operation, give opioids. It's like, so what are some of just a little more comment on how we could objectify patient outcomes a little bit better than the opioid issue, because I've seen some studies say, well, it didn't decrease opioids, so I'm not using it. Well, but the patients are doing so well. So first, I wonder, maybe Greg, you talk about that a little bit, the patient experience part.
Yeah, I mean, it's a very interesting question you pose. I mean, because when people are taking less opioids, are they taking them and accepting pain? Or are they taking them because they don't have pain, right? Those are 2 very separate things. I have one couple. I did all 4 of their knees over the course of about 18 months. And on their last post-op visit, the guy looked at me and said, you got me and my wife through all 4 knees and we never had pain. And that kind of really stuck with me because, and that gets the heart of it, right? Like, where these people weren't just accepting pain and not taking narcotics, they literally did not have pain. And there's a big distinction there. So I think that's what the iovera can do, and how to quantify that. I mean, I suppose, you really you could just have check in with the patients daily and have have them do a pain score. So it's one thing to look at narcotic use, but it's another thing to really look at their pain scores. And if their pain scores are truly 0 or 1, that's pretty impressive. I mean, it's I hear this, and it's what I was alluding to before, that 20% of superstars. Now it's like every day in my clinic, I'm seeing patients that come in, they said, I never had pain. I just never had pain. And it's like music to the ears of a knee surgeon. So,
And I remember when I was a resident, and my attending was Ken Krakow, great, world famous, great surgeon, and his patients were miserable. I mean, this guy was the preeminent, whatever, for total knee replacements and hips. And when I rounded on these folks, it was just, I mean, they were hitting the PCA pump like it was candy. And we've gone from that, and length of stay was 5 days, and we're prescribing, I don't even know, maybe a garbage bag full of Percocets, at discharge back then, to what, Greg's saying. I mean, it's a complete 180 from where we were, 10, 15 years ago.
See, one of my feelings is that yes, we do have an opioid crisis in America, but we really have a pain crisis in America. And if people, as Greg said, if people are coming in and saying, I have not had pain, that's a billboard, on I-95 or whatever is the highway down in Palm Beach, what I'm saying? I just didn't have pain, with Dr. Martin, and Dr. Levengood, I'm sure. And, and by the way, your backdrop, I think your office needs a little work there, Vin.
Yeah, it's too sunny outside, so I had to come inside.
Yeah, come say, good. Your home office looks like your operating room. Yeah.
Well, actually, it is, because I'm at the hospital.
Yeah, I think the other thing other than just pain is, we look at opioid use, but a lot of times when I talk to patients, I'm like, were you in pain when you took your opioids? And they said, no, but I just didn't want to have pain. So a lot of it is, we've got to kind of educate them a little bit more about, when they're really in pain. Because I think the biggest thing is they have this anticipation they're going to have pain. And so if they anticipate they're going to have pain, they want to take something so they don't have pain. And so a lot of it is kind of saying, maybe you don't need to actually, take the the Tylenol, or take the Motrin rather than taking the Percocet if you start having some mild pain. And so that would probably cut down on a lot of the pain medicine that we give them, they take because they feel like they should, because you gave it to them. There must be some reason you gave it to them. So the other thing, and the other thing is I've noticed, especially postoperatively, these patients, they walk sooner, they get better range of motion. It's hard to quantify, but when they're not in pain, they participate much better in the activities of daily living.
I think the other thing we need to do is, part of, I think, Avera and all these multimodal programs is setting the expectation appropriately, upfront with the patient. I think we all agree, in general, 0 out of 10 pain is probably unrealistic, not going to happen. We also don't want 10 out of 10 pain either. So what is that magic number that's appropriate? And, and I think, I forget, maybe it was Clay or Bill or somebody earlier was saying, Greg was saying we have such a spectrum, right? 20%, 20%. And so, can we create kind of a scale where, all right, so let's say our goal is really, we want 3 to 4 out of 10 pain for most of our patients. That's kind of acceptable to kind of, Tylenol, Advil, NSAIDs, and then have kind of an escalation protocol, knowing that we don't want 10 out of 10, but 0 out of 10 is not what, isn't going to necessarily happen either. And instead of giving everyone Percocet to get to 0, if they get to 3 or 4, we're all right. It's not the end of the world. They'll get through this. But, we certainly don't want them hanging out around 8 or 9. And, we've got all these strategies now to get them down into a manageable, reasonable place.
Then I think that's a good point too, because there's some patients too that I run into where expectations, you got to set expectations, because, we'll do Iovera and I'll have, that 20% where, Dr. Moore's talking about that, that say that it didn't really work for me. It's still uncomfortable. I'm still having pain. I'll then ask them, well, how much pain medication did you take? Oh, well, I only took a couple of pills. Well, what's your pain right now? It's about a 3, but it still hurts. So and that so it worked. It's helping you. Again, they don't have. This is their first surgery. They had Iovera, so they don't have a non-Iovera treatment to compare to. And so they still have a little bit of pain, but you just have to educate them on, look, this is not I sell it as not a pain-free solution, but a drastic decrease in your pain. There are some patients, yes, 0 pain, and they don't touch a pill at all. But I think it works across the board in some capacity to everybody. Even that 20% of patients that they say it didn't work for me. If you talk to them, they're moving better. They're doing things well before the average would without Iovera, and their pain thresholds are a 3 or a 4.
The other thing I'll just add, especially like in the chronic, it's true for TK potentially patients too, but especially in the chronic pain patients, to patients, pain is pain is pain. So it's not that infrequent. I'll just share one quick example. I don't think anyone's mentioned this, but I get an increasing number of referrals too that we do Iovera on because the patient's too obese to have surgery. So the goal is to do Iovera, help them feel better, help them then be motivated to lose weight. Maybe they're on Ozempic, maybe they're, working on their nutrition and all that kind of stuff. So then it's something to help them get to that point where they can get the total knee that they need. I've had people that now that I've done Iovera on the total knees that they had because they lost 50 pounds. So that's another use that you can use the cryoneurolysis for as well. But going back to what I was saying, pain is pain to a patient. But when you go, that's what I suggest a lot of times these people to come see us. Go see your orthopedic surgeon. Go see the person who did Iovera on you. Because, for example, there was one of those ladies that I saw that was going, trying to lose weight and of ultimately going to get a total knee. She came back, I think it was maybe 3 or 4 weeks after. She tells my staff, in the HPI, oh, it didn't work. I'm so sad. What am I going to do? And I go in and I start talking to her a little more. You touch her medial joint line, it's not hurting. You touch her lateral joint line, it's not hurting. And I'm like, well, where do you hurt? And she's like, it's just hurting right here. And it's all lateral. She's like, oh, by the way, I fell. And so I ultrasounded her and she tore her LCL. And the only pain that she was experiencing was an LCL tear. She didn't have the joint pain that she came to see me with after I did the Iovera. And so, I ended up bracing her and doing some PRP and she got better from that. But
hey, Vin,
I think it's important to find the pain generator.
Hey, Vin.
Yeah, Kevin.
I'd like to say that this has been an excellent discussion, but I would like to put in perspective that education is the most important thing. And as you know, the nurses have decided that there's something called a pain scale. So no matter what, someone hits the recovery room, they slam them with Dilaudid. You don't need to get permission because you're not in charge in a recovery room. And so the point is, I've had to write orders, no Dilaudid upon entering a recovery room, which causes a fight. I get called down to the president of the hospital, and I don't really care at my age. I couldn't care less. So the point is, because we have to fight for our patients. And what I'm saying is that the education process has to start not only with us, but with the nursing and also our patients. And so I will say, and cause a problem now with my own colleagues, it's the doctor's responsibility to have this conversation, not a PA. And if you have the conversation, they can be Hawthorne effect. And I agree with Greg, there's 20, but you can push it to almost 60, 40, or 70, 30 for it. And then lastly, there's no reason not to do an outpatient total knee at this point in life. And so if you can't get them, their heart, their diabetes to a rate, the answer is it's going to be a fight, but I look forward to it because today's conversation was so great because it was all about the patient. And that's what's so important. So I give you, and Ira, I see, God knows where you are in the world. Kudos for it. But this is really important. And I thank you for bringing it to light.
Yeah. Gary, were you going to say something?
I've always hated the pain scale. It doesn't make any sense. I have a patient that's functioning perfectly well, and you ask them what their pain is. Oh, it's 6 out of 10. And you're like, but aren't you doing all the things that you couldn't do before? Oh, yeah. Well, where did you come up with a 6? Well, I was kind of looking at your scale over there. Maybe it's more like a 4. And that's why it always irritates me, when patients do that kind of thing, because they really have no understanding of what they're saying as far as what their real pain is. And so I focus on, what are you able to do now that you weren't able to do before? How are you functioning? And if they are functioning and they're doing all the things that, they had this small little area that they couldn't do anything before, and now they're able to expand back out and do all the things they want to do, that's a win. And, whether you put a 4 on it or 2 on it or 12 on it, I mean, they're functioning. And that's what we do as surgeons, is create function in these patients.
Dan, you put a comment in here. Can you walk us through what you were talking about?
Sure. We were talking about setting expectations. I appreciate the comments as well about who's referring in the patients. We definitely have seen the PTs in our communities referring. I also have a tremendous number of patients who are telling friends about iovera for our practice. We've been doing it for 4 years and enjoying it very much. And when we're setting expectations for patients, I tell patients regularly before surgery, in the recovery room, and through their post-op visits, we cut off the end of the femur, the top of your tibia, and back of your kneecap, and jam metal implants in there. We don't expect you to have a pain-free recovery, but what we shoot for is our pain at or below your preoperative levels of pain, meaning when they're having a bad day of arthritis. And frequently, to the point about nurses in the recovery room, my tactic with nurses in the recovery room has been, when I go to see a patient acutely 1 hour, 2 hours after surgery, and they tell me their pain is a 4 or 5, and the nurse is grabbing 5 milligrams of morphine, I say, at home, what was your arthritis pain? Oh, all the time it'd be a 4 or 5 every day. What would you take for that? Oh, I'd take Tylenol or ibuprofen at home. Okay. And the nurses would put the morphine back in the Pyxis. And they would say, oh, you only take Tylenol or more ibuprofen for that. Yeah. The patient's like, no, I feel fantastic. They're like, this is best I felt in years. And they're within an hour or 2 from surgery, and their anesthesia's off, and they're walking around the PACU. And all of a sudden the nurses aren't snowing them. I'm not getting the dizziness. I'm not getting the hypotension. I'm not getting the nausea that they're not going home for because of those side effects from the drug choices in recovery. And we reinforce that at every visit. We see most of our patients post-op 7 to 9 days after surgery. Then we usually see them at 6 weeks and see them at 3 months. Absolutely, since we instituted iovera, not only has the quantity gone down, but we don't get refill requests on our stronger medications that are 7 to 9 day post-op. And they're asking us what to do with their leftover pills. It's led to a conversation of reducing the total quantity. We're down between 20 and 30 of our oxys and some tramadol. Most of our patients are on a scheduled Tylenol anti-inflammatory, and the iovera is the majority of their recovery period. So just setting expectations and then teaching. I think the nurses can help you or totally sabotage you. And I think the biggest thing we had was we sent a bunch of our nurses also to some orthopedic nursing certification, and they realized how much less we need narcotics and that we don't need Foleys, and that these patients all should be ambulating immediately after surgery. And we used kind of the John Cotter method of change management, and we made several of the nurses became advocates for reducing our narcotic usage, increasing our ambulation after surgery, and reducing the number of interventions we use.
Great, thanks.
Thank you.
Ira, I think we're up against the hour.
Yeah, this has been great. I fortunate for everybody that Dasa led this, who actually knows a lot about cryoneurolysis versus me. No, I want to thank everybody for coming. The Joey open mic sessions are always great. We're recording this. This will be available in a couple of days on the website and on the YouTube, and on our Spotify channel. We have a great panel tonight. Vin, thank you very much for moderating. A really superb job. I'll get you something for your office you have there. It'll be I am going to be taking an 8 a.m. flight tomorrow to Las Vegas to be
What's in Vegas?
There's a course called Ortho Summit. It started a decade or so ago by a guy named Kevin Plancher, and is now seems to run on its own with no
Thanks
effort.
to Ira, fellow
With
in
no-
residence section chair, 16 other chairs. If you're not there, you're a loser.
Well, it's 9 o'clock. We respect everyone's time here at Joey. A number of articles are coming out on cryoneurolysis. There are already some on Joey as well. I want to thank all the panelists personally and moderator and say good night.